Hello, my name is Janet and I'm publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision and continuing professional development. This year, medicine celebrates its 50th anniversary. In honour of this, we've put together a collection of podcasts recorded by the journal's chairman, Albert Ferro. We hope you enjoy them. If you want to find out more about medicine, including how to subscribe, please visit www.medicinejournal.co.uk.
Hello and welcome to the latest medicine podcast. My name's Albert Ferro. I'm a clinical pharmacologist at King's College London, and I'm delighted to have with me Dr Debashis Sarker, who's a medical oncologist at Guy's and St Thomas's and KCL. So welcome to you, Debs.
Thank you so much, Albert, for having me on. Delighted to be here.
Delighted. Good. And we're doing this as part of the 50th anniversary series of podcasts, but we're also doing it because the oncology issue is about to come out in January, I believe. So this is quite a good time to be talking about oncology and advances in that anyway, and signposting people to the issue.
Absolutely.
So maybe I could start off by just getting some general thoughts. I mean, when I was a trainee, oncology was a very different field to what it is now. Cancers were treated in very crude ways, I would say. There was surgery, there was radiotherapy, and there was chemotherapy. And the chemotherapeutic drugs that were available were fairly toxic things. And the advances were all fairly incremental. But things have changed a lot in the interim. And I wondered if you could just give us a bit of an overview of what's changed in that time.
It's certainly a very exciting time to be an oncologist. As you say, Albert, a lot of change has happened over the last decade or so. And I suppose there's probably a couple of things that have really made a kind of transformational impact in terms of therapies and outcomes for patients with a whole range of different types of cancer. I think the first one is really around the immunotherapy revolution. So many people will be aware that we now have really been able to successfully harness the immune system to treat cancers, and the kind of commonest group of drugs that we now have at our disposal in many cancer types is the group of drugs called the immune checkpoint inhibitors. And certainly for some cancer types, these have been really associated with very significant improvements in survival. So things that were very difficult to treat previously, such as advanced melanoma, renal cell carcinoma, non-small cell lung cancer, have really had a significant shift in terms of survival outcomes for patients with advanced disease. And dare I say it, some of these patients even are looking at long-term remission of their disease and even cure. So really, the immunotherapy revolution has really been such a huge advance for us. You mentioned, Albert, about some of the issues around toxicities of, cytotoxics, which I hasten to add, we still use a lot for many types of cancer. And it's not that immunotherapies are without their own issues or complications. They have a whole different series of toxicities that we've had to learn about and adapt to, and certainly that's part of the upcoming medicine chapter, where we have an immunotherapy section and some discussion around immunotherapy related toxicities. The other aspect in terms of immunotherapy are this group of therapies, which so far has been predominantly in hematological malignancies. So these are the cell therapies such as CAR T-cell therapy. And for those of us like myself who treat patients with solid cancers, we're hoping that some of those cell therapies, CAR T, something called TILs, tumor infiltrating lymphocytes, might have an impact in addition to the immune checkpoint inhibitors that I've mentioned. Mm-hmm. So immunotherapy is one group which I think has really led to a significant change over the last 10, 15 years. And the other area is really around increasing use of precision medicine and developing better molecularly targeted drugs against specific gene targets, which, again, for many cancers has had a significant impact.
Yes, I mean, that's a big area in many areas of medicine, isn't it? I mean, my particular thing of clinical pharmacology and therapeutics, precision, personalized medicines is very much a thing. But here we're talking about identifying, profiling tumors more precisely, their genomics and so forth. And that sounds really exciting, that you can really target therapies there. Is that something that has really come of age, do you think, or is there still a lot to be done there?
Definitely, compared to 5-10 years ago, we are doing more extensive gene sequencing. The number of cancers where there are specific molecularly targeted drugs related to, gene mutations or gene fusions has definitely increased, and that will only increase going further forward as we do better and more comprehensive genomic profiling. And as we have better drugs, and I just maybe give one example. So, many of you will be aware of a gene that is often goes wrong in many patients with lung cancer, pancreatic cancer, bowel cancer, called KRAS. So KRAS had hitherto been a very, very almost impossible target to be able to drug effectively. We now have the very first wave of KRAS inhibitors against specific KRAS mutations, predominantly for the group of KRAS mutated non-small cell lung cancers. So those advances in kind of clinical pharmacology, medicinal chemistry are kind of going hand in hand with our improvements in terms of genomic profiling, really to be able to take things further forward. And as I said, things that we would have thought to be undruggable even 5-10 years ago now seems to be within our grasp.
And you mentioned a couple of areas, a couple of cancers where modern immunotherapies and related therapies have made a difference. You mentioned melanoma, I think, and renal cell carcinoma. There's probably a couple of others as well that we could talk about as well. But there's also other areas where things haven't changed that much. Would you say that's fair?
All cancers are not equal in this progress, I'm afraid. So other cancers where there's been really a very significant change, I mentioned non-small cell lung cancer, and that has pretty much been the kind of poster child, both in terms of the immunotherapy revolution, but also in terms of precision medicine and obviously being able to identify groups of patients with specific genomic aberrations, be it gene mutations such as EGFR or gene fusions, things like RET or ROS or ALK, which have specific drug partners. So on the one hand, you have these cancers like non-small cell lung cancer, renal cancer, kidney cancer, where, as I said, immunotherapy, precision medicine has really made a big impact. Unfortunately, however, there are a group of cancers where the impact of things like immunotherapy and our ability to be able to do precision medicine has been much less. So one of the main areas of cancer that I treat is pancreatic cancer. And unfortunately, immunotherapy for pancreatic cancer is not effective. So those same immune checkpoint drugs that we give to patients with non-small cell lung cancer or to melanoma, completely ineffective in pancreatic cancer. And that's actually related to our, to the tumor immune microenvironment. Actually, what's happening in pancreatic cancer is that there's a kind of immune desert around the cancer cells. So immune cells can't infiltrate within pancreatic cancer, and these drugs are ineffective. And again, things like the precision medicine revolution hasn't really kind of we haven't been able to to define to develop specific drugs against many of the genomic targets that we know about in pancreatic cancer. I mentioned about KRAS. The common KRAS variant in pancreatic cancer actually is still, we haven't been able to drug. So these are some of the challenges that we have, that some cancers clearly, we've made really significant progress, and other cancers, I'm afraid, such as pancreatic cancer, survival rates have been unchanged for the best part of, 30, 40 years.
So obviously part of the challenge is developing better therapies, and we've talked a bit about some of those, and that's obviously very helpful. And I guess the other side of it, which is obviously also receiving a lot of publicity at the moment, is earlier detection of cancers. Because, of course, if we can detect them earlier, we've got a better chance of curing them, or at least treating them more effectively. And I think there's been a lot of advances in that area as well, haven't there?
Absolutely. And I think it's increasingly become an area around which both as an academic community and a clinical community, and increasingly in terms of public health and priorities from a government health spending perspective, I think it's become increasingly important. For example, in the UK, we know that our survival rates historically are a lot lower compared to many other developed nations. Say, for example, in Europe and America and Australia, with regards to many cancers. And we think that one of the main reasons that our survival rates are not as good is because, unfortunately, we are detecting patients at a more advanced stage or a later stage. And then that leads to an increased percentage of patients who you're not able to offer definitive curative therapy, which for the most part is still very much around surgery and radiotherapy. So we've got to be able to improve early diagnosis and detection. And there's a whole series of different initiatives around this, which I think hopefully will play an increasing role. One of these is around the increasing use of liquid biopsies. So liquid biopsies are our ability to be able to detect circulating DNA, cell-free DNA, and do sophisticated molecular analyses to be able to identify, genomic aberrations or cancer-related signatures that potentially enable a patient with perhaps, let's say, non-specific symptoms that, we're not sure whether the patient might have cancer or not. The ability to do that type of assay in a way to complement existing diagnostic strategies, be it imaging or endoscopy, etc. We hope that will lead to improvements in diagnosis, and clearly there could be utility in this in terms of screening largest groups of potential at-risk populations. So it's certainly a very active area of research. And I think also, alongside that, we've had this big thing at the moment in cancer around how we might use AI, artificial intelligence, to be able to, to screen large cohorts of patients potentially at risk populations. So I think, increasingly we'll have those kind of advances that will come into play, and as I said, complement very much what we do already in terms of diagnostics and imaging.
I think we were discussing, you were telling me about a specific trial that's going on at the moment, the GRAIL test, is that right? Which is aiming to go out there and detect those cancers early by means of a blood test.
So that's one example of one of these liquid biopsy tests. So actually what this particular test picks up is a methylation signature that can detect, and each detects over 20 different types of cancers, and each cancer has its own unique methylation signature that you can pick up. So there is a trial which is currently being run in the NHS called the GRAIL study, the GRAIL-Galleri study, which is screening populations at risk in certain areas of the country to be able to, as I said, hopefully be able to detect cancer at an earlier stage compared to obviously the kind of traditional routes.
Thank you, Deb. So we've talked a bit about some of the newer therapies, and obviously these cost. We've talked about newer diagnostic methods, which obviously cost as well. So there's a lot of funding issues around all of this, and I wonder what your thoughts are, particularly as in our position, we work within the NHS and so forth, which is chronically cash poor, as we know. There are clearly going to be challenges, both in terms of funding provision, but also the logistics of rolling initiatives such as this out. What are your thoughts about that?
I think that the issues around funding are complex, and I think many of us who advocate a kind of precision medicine type strategy actually feel that, that kind of one size fits all approach that we have for cancer actually is not very cost effective. And actually, if you're able to define cohorts of patients that related to, as I said, either a genomic signature or some other aspect of personalized medicine, and the impact of those therapies is likely to be greater from a health economic perspective, those kind of approaches actually in the long run are likely to be able to provide us as a society with a more cost-effective, approach to treating patients with cancer. So, but there's no doubt that we're obviously, a lot of what we're talking about is expensive. Cost of doing, the cost of, for example, giving immunotherapy is not cheap. The cost of things like CAR T cell therapy for hematological cancers is not cheap. But I think that the aim really ultimately is for us to move to as I said, a kind of societal model around which, we're able to move from that, as I said, that kind of one size fits all to more kind of clearly defined patient cohorts and so on. And I think that will enable us to get those kind of cost savings on on a societal basis. I mean, for example, the cost of next generation sequencing to look at your genome, historically that has been very, very high. And if you look over the last 10 years, the cost of that has come down dramatically. So, when we did the Human Genome Project, it cost millions, if not $1 billion. And now the cost of doing a patient's genome is hundreds to a couple of $1,000s, depending on where you do it. So, those kind of cost efficiencies, I think, will enable us really to provide, those kind of real technological achievements in a much better, more focused way, and really make much more sense from a health economic perspective.
I mentioned the upcoming issue, and of course the whole journal is very much geared towards general medicine trainees and keeping up to date with things in general medicine. A lot of what we've talked about here is quite specialised. It's very, very interesting, and I'm sure that people who are listening and watching this will find it really interesting. I guess from the general medicine point of view, how will they come in contact with patients with oncological issues? And I guess that brings up the issue of oncological emergencies. That's when, I guess, they might come to the attention of the medical registrar, for example. I don't think we will necessarily have time to go into those in detail in this podcast. Perhaps just say a few words about the kinds of things that might come the way of the general medical registrar, and maybe tell them a bit about where they might find the information in our journal.
Yeah, I think that, as a general medical registrar or junior doctor, many of the kind of scenarios around which you might see a patient with cancer are related to an oncological emergency, and these might be things like development of spinal cord compression, neutropenic sepsis, complications from drugs such as immunotherapy, and as I said, as we were talking about, some of those things have evolved over time as we have a different kind of cohort of patients being treated with a different range of drugs. So I think from a general medical perspective, it's important to be aware of those kind of things that potentially, a patient with cancer undergoing systemic therapy might turn up to an accident in an emergency department with, and how you have an approach to be able to manage that. So within the oncology chapter of medicine, we have a specific section on oncological emergencies, which covers many of those aspects. We have specific topics in terms of different classes of systemic therapy and toxicities related to those, be it cytotoxic chemotherapy, hormonal therapy, targeted agents, immunotherapy, as we've mentioned. And also, so there are certain cancers which are, clearly very common, things like breast cancer, lung cancer, gastrointestinal cancers, and those are perhaps the commoner cancers that you potentially would see patients with. And again, we have chapters within the oncology section specifically related to these areas. So I think that will hopefully give the reader a really good overview and insight in terms of the kind of day-to-day management of these patients in terms of problems and complications that arise from patients with these types of cancers, and the kind of treatments that they have, and the side effects that might occur that would lead somebody to come to accident and emergency, for example.
Good, thank you. That's a good plug for the journal. Thanks, Debs. Maybe I'll close by asking you to have a look into your crystal ball, if I may. Let's say 10 years down the line, where do you think we'll be in terms of outcomes with cancer? I mean, at the moment, it's still one of the greatest causes of mortality. It's pretty much vies with cardiovascular disease. It's up there, and so it still causes a lot of deaths out there and a lot of morbidity as well. I know it's very difficult to predict these things. Where do you think we'll be in, let's say, 10 years' time? Will things have turned a corner? Will we be doing will we be doing better in terms of cancer outcomes, do you think?
I think it's an exciting time, and I think there's every reason to be optimistic. I think that the fact is that 1 in 2 of us at some point will develop cancer in our lifetime. That's as a society, as a nation, we are getting older, and as you get older, the risk of cancer increases. So we definitely will, many of us will develop cancer. Many of us will know people who are affected by cancer. And as clinicians, we have to be aware of those kind of changes that are occurring. But as I said, I think there's every reason to be optimistic. I think we are getting better at the drugs that we have at our disposal. I think, as I said, the immunotherapy revolution will continue apace. We'll get better at being able to do precision medicine, increasing use of genomics, increasing use of, for example, being able to understand when a drug stops working, what the resistance mechanisms are, and then being able to switch therapy accordingly. So it's a kind of key area that I think we will be working on. And as I said, improvements, I think, in terms of early diagnostics, increasing use of artificial intelligence. I think these are really the kind of way forward for us, really to be able to manage cancer effectively in the decades ahead.
As you said, Debs, I think it's a very exciting time in oncology at the moment. A lot going on. I want to finish by thanking you very much for your time. Thank you very much for talking to us today.
Thank you, Albert. Pleasure to speak to you. And yes, just a message, another plug to the readers to please go to the Oncology Journal, and you'll see a lot of the things that we've discussed today in print there.
Wonderful. Thanks a lot.